Hello and welcome to this antenatal case study presentation. Today we will discuss Jane. Meet Jane. Jane is 35 years old. This is her first pregnancy. She has a BMI of 35. She has a medical history of polycystic ovary syndrome and a family history of type 2 diabetes. Ladies who have the following risk factors are at risk of developing gestational diabetes during their pregnancy. These include a BMI above 30, previous macrosomic babies weighing 4.5 kilograms or more, previous gestational diabetes, a family history of diabetes, i.e. a first-degree relative with diabetes, or an ethnicity with a high prevalence of diabetes. Jane showed two risk factors. She had a BMI above 30 and a family history of diabetes. Jane is sent to have an oral glucose tolerance test at 28 weeks into her pregnancy to determine if she has gestational diabetes. Her glucose levels are checked before the glucose challenge, which is a sugary drink, and then again 2 hours after. Her results show a blood glucose level of 5.4 before the sugary drink, and then a glucose level of 8.1 2 hours after the drink. A diagnosis of gestational diabetes is a fasting plasma glucose level of 5.6 or above, and a 2-hour post-plasma glucose level of 7.8 or above. Therefore, Jane's results confirm that she does have gestational diabetes. Jane is given a blood glucose monitor and advised to test her blood glucose levels 4 times a day. On waking, before food, and 1 hour after each meal. Her target glucose levels are less than 5.3 on waking and less than 7.8 1 hour after meals. Jane is seen in clinic 2 weeks later. She's concerned that her glucose levels are sometimes higher after meals. We have 3 options to help Jane bring her glucose levels down. Number 1, diet and lifestyle changes. Number 2, start metformin. Or number 3, to start insulin. Which would you choose? Jane recognizes that her glucose levels go above target after particular meals. This suggests that there is scope to make dietary changes to help keep her glucose levels in target. She's seen by a dietitian in clinic who recommends choosing a high-protein breakfast meal instead of a carbohydrate-rich cereal, trying to have fruit in between meals as a snack rather than with a meal, try to reduce the amount of carbohydrate food with a meal and bulk up on more salad, vegetables, and protein, and to stay active after eating to help keep the glucose levels down into target 1 hour after. Jane comes back to clinic 2 weeks later. She is now concerned that her fasting glucose levels are high. She confirms that she is not eating overnight, so we have 3 options to help Jane to bring her glucose levels down. Number 1, diet and lifestyle changes. Number 2, start metformin. Or number 3, to start insulin. Which would you choose? Jane's glucose levels are in target 1 hour after meals. Diet and lifestyle changes will not help to bring her glucose levels down before breakfast the next day. Jane therefore requires glucose lowering medication to help bring her fasting glucose levels into target. Metformin and insulin are 2 glucose lowering treatments recommended for use in pregnancy. National guidance supports the use of metformin as first-line treatment. Jane is prescribed metformin 500 milligrams to take with her evening meal. This can be built up to a maximum dose of 1 gram twice daily. Finally, it is important that Jane continues to monitor her glucose levels regularly and has regular contact with her diabetes and antenatal team until delivery. Her glucose levels are likely to change as her pregnancy continues, and she may require more support or glucose lowering treatment. See the following presentation for more details on postnatal considerations. That concludes the end of this interactive case study. Welcome to this presentation, which explores the care of women with diabetes during and after pregnancy. In this presentation, we will discuss the following: preconception care of women with diabetes, antenatal care and considerations, gestational diabetes screening, intrapartum planning and care, postnatal and neonatal care. In the UK, approximately 5% of all pregnancies involve diabetes. 42,000 are from gestational diabetes, an amount that is increasing each year due to the levels of obesity and more pregnancy in older women. 3,600 are from type 1 diabetes, and 2,400 are from type 2 diabetes. Living with diabetes during pregnancy has an increased risk of complications such as retinopathy and neuropathy. It also has increased risks for the baby, such as neurological complications like spina bifida, large birth weight, preeclampsia, stillbirth, or neonatal death. In relevance, 50% of all fetal and birth complications are due to maternal diabetes. These risks, however, can be reduced by planning ahead and optimizing glucose control during pregnancy. For women with pre-existing diabetes, planning for pregnancy should be emphasized, particularly as the National Diabetes Pregnancy Audit highlighted that 7 out of 8 women do not have preconception care. Blood glucose management should be discussed during the planning, and if blood glucose levels are unstable, contraception should be encouraged until glucose levels are within a healthy range. In relevance, NICE recommends a HbA1c target of 6.5% or 48 millimoles, if no greater risk of causing hypoglycemia, fasting glucose levels between 5 and 7, and pre-meal glucose levels between 4 and 7. In regards to medication, 5 milligrams of folic acid is recommended and encouraged to continue for the first 12 weeks of pregnancy, as this helps to reduce the risk of fetal neurological defects. For glucose-lowering agents, apart from metformin and insulin, all other agents should be stopped. Statin, ACE inhibitors, and ARBs should also be discontinued before pregnancy or as soon as pregnancy is confirmed. If a woman has a BMI above 27, then weight management should be offered. Retinal screening and renal assessment requires to be offered before conceiving, as eye and kidney health needs to be monitored closely. To support preconception care for women with diabetes, Eden has developed a useful one-page infographic. The aim of the infographic is to provide healthcare professionals with key information quickly at a time of need. Eden also has a range of other infographics for managing diabetes, including lipid and blood pressure management, diagnosing diabetes, hypoglycemia, sick day rules, and many more. For full access to the range of Eden infographics, please use the link on the screen. During pregnancy, women with diabetes need to be aware of the required daily glucose tests and test targets. If undertaking dietary and lifestyle intervention or taking oral glucose lowering therapy, then glucose levels should be monitored 4 times a day before breakfast and 1 hour after meals. If on multiple daily insulin injections, glucose monitoring should occur 7 times daily before meals, 1 hour after meals, and before bed. In relation to target glucose levels, NICE recommends that women with diabetes during pregnancy should aim for a fasting glucose level of 5.3, a 1 hour post-meal glucose target of 7.8, or a 2 hour post-meal glucose target of 6.4 if the 1 hour glucose target is not met. HbA1c should be measured at the first appointment and during each trimester with a target of 6.5% or 48 millimoles or below. Antenatal care for women with diabetes also requires extra considerations. During pregnancy, there is a higher risk of developing ketones at a lower glucose threshold, so ketone monitoring education and equipment needs to be provided. If a pregnant woman with any form of diabetes presents with hypoglycemia or is unwell, ketones should be checked. If suspected diabetic ketoacidosis, immediately admit to hospital. Glucose monitoring technology should also be considered. NICE recommends for all pregnant women with type 1 diabetes to be offered continuous glucose monitoring technology. This is because the technology helps to meet blood glucose targets and improve neonatal outcomes as identified in a landmark research such as the CONCEPT study. CGM is a small device that measures glucose levels at regular intervals through the day and night, allowing for enhanced glucose monitoring. It can also be used for pregnant women on insulin therapy who do not have type 1 diabetes if they have problematic severe hypoglycemia or unstable blood glucose levels that are causing concern. Alternatively, if CGM is not possible or suitable for people with type 1 diabetes, the Freestyle Libre can also be offered, which is a flash glucose monitoring device which helps a person to test their glucose levels without needing to regularly prick their fingers. In the UK, approximately 16% of women develop gestational diabetes during pregnancy. Screening for gestational diabetes should be offered at 24 to 28 weeks if a pregnant woman presents with any of the following risk factors: a BMI above 30, previous macrosomic baby weighing 4.5 kilograms or more, previous gestational diabetes, a first-degree relative with diabetes, ethnicity with a high prevalence of diabetes, such as South Asian, African Caribbean, or of a Middle Eastern background. Screening requires the use of a 75-gram 2-hour oral glucose tolerance test, or for women who have had previous gestational diabetes, offer the 75-gram glucose drink challenge. A fasting glucose should be taken prior to the test, with a further plasma glucose performed 2 hours after the 75 grams has been consumed. Diagnosis of gestational diabetes is confirmed if the fasting level is 5.6 or above, or the post 2-hour level is 7.8 or above. When women are diagnosed with gestational diabetes, they should be offered a review with the Joint Diabetes and Antenatal Clinic in 1 week. To help manage gestational diabetes, changes to diet and lifestyle are recommended by encouraging the person to avoid sugary food and drinks, avoid large carbohydrate portions, eat little and often, staying active by exercising after meals. All women with gestational diabetes should be referred to a dietitian. For women with diabetes undertaking diet and lifestyle interventions during pregnancy, if glucose levels are not in target within 1 to 2 weeks, glucose lowering treatment should be provided. The first consideration is metformin, which can be prescribed up to 1 gram twice daily. If metformin is not tolerated or additional glucose lowering therapy is required, then insulin should be used, or with an isophane insulin recommended as the first choice in order to bring down fasting glucose levels, then rapid-acting insulin to help reduce postprandial rises. Also consider the early use of insulin with or without metformin if a pregnant woman with diabetes presents with a fasting level of 6 millimoles or above, or 7 millimoles or above at diagnosis of gestational diabetes. If insulin is used during pregnancy, the woman should be made aware of the risks of hypoglycemia and be advised to always carry hypotreatment with them. Immediate contact with a joint diabetes and antenatal clinic should be offered for pregnant women with diabetes, with regular follow-up every 1 to 2 weeks throughout the pregnancy, assessing blood glucose control and providing ongoing information and education where required. Another important part of antenatal care is performing assessments of the eyes, kidneys, and fetus. For pregnant women with pre-existing diabetes, retinal screening should be offered at or soon after the first antenatal appointment, unless they have had eye screening in the last 3 months, then around 28 weeks. If early stages of retinopathy are found, another test is required to be offered between 16 and 20 weeks. If significant retinopathy is found or images are not clear enough, a referral should be made to an eye specialist. Kidney health should also be monitored. If the woman has not had a renal assessment within 3 months prior to their first contact, an assessment should be arranged, but not using EGFR. The fetus should also be monitored during pregnancy by performing an ultrasound scan at 20 weeks to detect for structural abnormalities, and from 28 to 36 weeks to monitor fetal growth and amniotic fluid. The fetus should also be monitored during pregnancy by performing an ultrasound scan at 20 weeks to detect for structural abnormalities, and from 28 and 36 weeks to monitor fetal growth and amniotic fluid. Planning for labour is an essential part of pregnancy. One should discuss the timing and mode of birth, especially during the 3rd trimester with the individual. Advise pregnant women with type 1 and type 2 diabetes with no other complications to have an elective birth by induced labour or caesarean section between 37 and 38 weeks plus 6 days, or before 37 weeks if they have a metabolic, maternal, or fetal complication. For women with gestational diabetes, advise to give birth no later than 40 weeks plus 6 days, but consider before if they have other complications. During labour, blood glucose monitoring should be performed every hour with the aim of maintaining glucose levels between 4 and 7. If glucose levels are not maintained in target, use intravenous dextrose and insulin infusion. Finally, to finish off this presentation, women with diabetes require effective postnatal care. Women with pre-existing diabetes on insulin should reduce their insulin dose immediately after birth and continue to regularly monitor their glucose levels in order to further titrate the dose appropriately. Explain to the individual that the reason for the dose adjustment is because they are at an increased risk of hypoglycemia during the postnatal period, especially when breastfeeding. If the woman is breastfeeding, advise them to have a meal or snack before or during feeds to further reduce the risk of hypoglycemia. Continue to avoid any medicines that were previously stopped for pregnancy. Women with gestational diabetes should have all their glucose lowering therapy stopped and be offered a fasting plasma glucose test at 6 to 13 weeks post-delivery and an annual HbA1c test, as they have a 50% increased risk of developing type 2 diabetes.
Hello, I'm Rachel and this is Michael. We hope that you found the animated case study and the slideshow a really introduction into the management of diabetes in pregnancy. The next discussion is going to be around the use of technology in the antenatal clinics. So, Michael, I thought we could start by talking about the advancements in technology which have helped to support patients during their pregnancy.
So there's been many technical advancements in recent years, and I suppose for people living with type 1 diabetes, one of the most noticeable changes has been the recommendation from NICE that continuous glucose monitoring, or CGM, should be offered to all ladies with type 1 diabetes during their pregnancy. I guess this follows the CONCEPT trial, which was done in 2017, and this was a randomized controlled trial, or an RCT, which compared glycemia and pregnancy outcomes for ladies who were either using capillary glucose testing or CGM. And what it found is that with ladies who were using CGM, they had more time spent in target, in glucose target, less time spent above target, and significantly better neonatal health outcomes.
That's right. And I suppose time in range is a relatively new change in how we look at people's glucose control. It's worth mentioning that CGM technology continuously monitors levels across the day. And it is because of this that we are able to see the amount of time someone with type 1 spends in above and below or within that glucose range. Another benefit of CGM is the alarm feature, which alerts a user when their glucose levels are high or low. Did you want to explain a little bit more about this information in clinic?
Sure. So I suppose CGM gives us the option to review glucose data remotely. And for people who have diabetes and are using CGM devices, they can actually upload their data from home onto their online account, onto a secure web-based platform. And with their permission, we tend to send them an email with a link inviting them to share their data with our clinic account. And this means that we can review their data without them needing to be present in clinic. So we can actually review their data remotely. And this has opened up the opportunity to run virtual clinics with patients' glucose data available in real time. The ability to review glucose data remotely and run virtual clinics has really helped us as a team to reduce footfall in clinics, which has been really important for patient safety throughout the whole pandemic. And CGM technology has really, it can be offered to ladies with type 2 diabetes or GDM if they're on insulin treatment or trouble with hypos. But I suppose, as you know, Rachel, that's not really the technology that would offer to ladies with type 2 diabetes or GDM.
Yeah, that's right. Instead, we use other technologies such as smart meters. So these are capillary glucose meters, which are able to link the patient's mobile phone, and therefore from that they transfer the glucose data across. And this then allows patients to review their glucose levels on their apps rather than write them in diaries. And glucose data from the smart meter app can then be shared with the clinical staff via an email or even uploaded to a glucose data sharing platform like the GDM Health app. You have a lot of experience using the GDM Health app in Antenatal, haven't you, Mike?
Yeah, that's right. The GDM Health app is one of the NHS approved apps for managing diabetes in clinic. And it allows patients to upload their glucose data from their meter onto an app on their phone. And with their consent, we can link their account with our clinical team or our clinical account. And this allows us to remotely access their glucose data, similar to what we do with CGM. And additionally, it allows patients to add extra information on meals eaten, medication taken, and acts as a really good educational tool for patients to identify patterns in their glucose levels.
It's also worth mentioning that these technologies have been pivotal in being able to work remotely during the pandemic. So the use of these technologies has reduced the footfall, as you said, Mag, by roughly about 50%, as well as providing more contact points to review patients' glucose levels and triage the patients who require consultation with the most appropriate healthcare professional. So moving on to postnatal, a question I get asked by a lot of patients is whether they need to change their medication doses once they give birth. What advice would you give in these situations, Michael?
Well, Rachel, as we know, insulin resistance in pregnancy is caused by maternal hormones, which are released during the pregnancy. So once ladies give birth, the concentration of these hormones in the body drop. And more often than not, the insulin sensitivity returns back to what it was. And this is why NICE guidance recommends that women with pre-existing diabetes should reduce their insulin treatment back to what it was before the pregnancy, and to monitor their glucose levels regularly to identify if they're on the appropriate dose of insulin. For women with gestational diabetes, it's normally recommended that their glucose-lowering therapy stops immediately after giving birth. And for some ladies who are concerned about medication some ladies are concerned about the medication that they take for their diabetes and whether that medication passes through into the breast milk. Is this something you've been asked before?
Yes, Mike, it's something that we're asked frequently, and it's a really good question. It's important that ladies who are breastfeeding continue to avoid medications that have been stopped during pregnancy. And these are normally blood pressure or cholesterol tablets, which are normally statins or ACE inhibitors. If they're on insulin treatment, then they should also be informed that there is a risk of hypoglycemia whilst breastfeeding or expressing breast milk. We'd also advise them to take regular carbohydrate snacks and seek medical support if their insulin doses are causing them to be troubled by hypoglycemia. Finally, I think it would be worth just talking about something that we both get asked in clinic, which is whether having gestational diabetes means that the diabetes is going to come back.
Absolutely. I mean, we know that women who have GDM or gestational diabetes are more likely to get it again in the future. And in fact, around 50% of women who have GDM go on to develop type 2 diabetes later on in life. And that's why the NICE guidance recommends that all ladies who have GDM have a HbA1c test at 13 weeks to rule out the diagnosis. Finally, we make an effort in clinic to warn patients of the risk of developing type 2 diabetes later on in life. And the advice that we give on diet and lifestyle is also there to help to reduce that risk of developing type 2 diabetes. But importantly, if ladies' HbA1c result comes back with that suggesting a high risk of developing type 2 diabetes, so for example, if the HbA1c comes back at 6 to 6.4%, or in new money, it'd be 42 to 47 millimoles, it would suggest that they should be offered a place on an NHS diabetes prevention program.
Thank you, Mike. Well, that brings us to the end of this discussion. Thank you for watching, and we hope you found this video useful. Goodbye.